This time, I'm just going to start with the same thing. History is important, but it's especially important when you're dealing with stroke. And the most important question is, was it an acute onset? Because if it's not an acute onset, there's always other things in the differential. What is the time of onset? Because for treatment, whether it's 4 or 6 or 8 or 24 hours, changes your algorithm for what you're going to do. And so you need an exact history and physical exam. And you need to know, the laterality, because things cross, left, right, and weakness, speech, all of those things. But you're going to see, I can give you the take-home message from this entire talk right now, which is that the bottom line is that there is an enormous amount of information in the non-contrast CT, and that's part of the reason I spent the last talk going over how to really look at a non-contrast CT really carefully and really well. And let's just start with this. There's a finding there, and the finding is a hyperdense middle cerebral artery at the M1-M2 bifurcation. In the right clinical context, that could be a lot of things. It could just be street artifact if the patient is tilted. So you have to look at everything and take it in context. But if it's real, and if there is contralateral right-sided hemiparesis, and it was acute onset, then that is just as good as doing a CTA and saying there's a vessel occlusion there. And you could also look at the basilar. And one of the biggest misses among everybody, our staff, our residents, our fellows, is forgetting to look at the basilar and see if there's a hyperdense vessel there. And that's one of those things where it's the easiest thing to see, but it has to be in your search algorithm. You have to remember to look for it. But just looking at the hyperdense basilar part of your search algorithm. Okay, and in fact, this is such a useful sign that back before CTA was the standard of care, and I know that's a little controversial because I've had some interesting discussions at lunch, and I guess CTA is not done on every stroke patient here, but for reasons we're going to discuss, it is the standard of care in the US. And before we had CTA to look for a large vessel occlusion to decide who was a candidate for catheter endovascular thrombectomy, EVT, we would look at the length of the dense vessel. And this is like a very famous paper by this guy named Riddell from Europe. And this is what, before CTA was routine, this is what everyone used to decide who to do EVT on. And basically, it turns out that if the hyperdense vessel length, and to get the accurate length, you need to look at the fins and connect the dots, but the length greater than 8 millimeters, IVTPA alone is not going to open up that vessel. Those are the cases you have to do thrombectomy. Okay? And also remember, at least for us in the US, there's a lot of regulations. There is a lot of approval of stroke centers. Like here in Santiago, there's only a handful of stroke centers that can do endovascular thrombectomy. But in the US, it's very tightly regulated, and you get it graded by the hospital accreditation. And are you a general hospital? Are you a primary stroke center where you're allowed to do IVT, IV thrombolysis, but not EVT? Or are you an EVT thrombectomy center, which is the highest level of comprehensive stroke center? There are only like 8 of those in all of Massachusetts, 5 of which are in the greater Boston area. And so it's very important for us to retain this rating, that we have a very careful record of complications, who develops hemorrhage after treatment, and what the staging of that hemorrhage is. Is it HI1, HI2, PH1, PH2? And so we actually have a little template where you could just look at the pattern of the blood, click on it, and it actually inserts that into the report. And so that becomes searchable. and our neurologists love that. I showed this before, but even more important for this talk is this paper. Anything you want to know that I'm going to say that has to do with our CTA, CTP, non-contrast CT imaging algorithm is going to be in this paper. So you could just go find this review. But I'll point out a few things. Again, the theme of this talk is how important non-contrast CT is. So you're looking for subtle signs of low attenuation, subtle signs of edema. What are some of those signs? There's the insular ribbon sign. It turns out that has a lot of prognostic value. We're going to come back to that. The lenticular sign, very subtle asymmetry. We heard in the other lecture about the spine trauma. Look for symmetry in part of that escape mnemonic. Look for symmetry. That's how you're going to find these subtle things. And one thing we're going to show is that aspect score, it's not worth obsessing over aspect score. Technically, to do EVT based on all the big clinical trials, you should have an aspects greater than or equal to 6, but that has changed because there's now a bunch of trials that came out that are getting, every major medical society has new guidelines, and it basically says large core is okay, and people are not even worried so much as using the aspect score as an exclusion criteria, and we're going to get to that too. You know, I've been thinking about non-contrast head CT for over 20 years, and basically there is a stroke here. There is subtle low attenuation, and if you look at the gray-white differentiation, you can actually see it, which side is it worse on, but it becomes a lot easier to see if you use those very narrow windows of outwards. That's why I spent time in the first talk explaining that those are Hounsfield units and what they mean and how to use them. And gray matter is about 35 Hounsfield units, and white matter is about 25 Hounsfield units. And these Hounsfield user measurements are plus or minus 5 to 10. So they're very, very close and very, very noisy. But if you really window down to the difference between gray matter and white matter, you can see here, if you squint and look at it small, 12:1, that there's loss of gray-white differentiation on that side. And we've come full circle, because again, we wrote this paper over 20 years ago, but we're writing a new paper that we haven't even, we're sending it out on Friday, which is 2 days, to see if it'll get published. And I'm going to show you some of the preliminary results from that. But it just comes back directly to this. And basically, this is the follow-up scheme. So you can see that that was the ischemic study. And this was the paper, and that was from 1999, and there were some other papers. But just by changing the display settings on the window and levels, we went from flipping the coin almost 50-50 to seeing very sensitively early edema. And I'll jump to one of the punchlines, earlier than you could see on any MR sequence except for a diffusion, except for an ADC, much earlier than FLAIR, way earlier than FLAIR. And this paper was also written by all my friends. Some of these are like co-authors of the paper I just told you about that we're working on, but it's all water. That's what you're seeing on NCT. You're seeing edema. Is it all water? I'm exaggerating a little bit. It's actually not all water, because some of it is actually blood pool. And remember I said that you could put a cursor on the aorta and that you could read the hematocrit. And if you take gray matter or white matter plus the hematocrit, that actually increases the density. And if you have an occlusion and the blood isn't reaching there, there is some subtle low attenuation that is not from edema. That is just from the fact that there's an occlusion and the blood isn't getting there. So the super early low density is probably what matches on the diffusion scan that we call cytotoxic edema. But in cytotoxic edema, remember, there's no net crease in tissue water. The total tissue water is the same, it's just that water is trapped in the cells because the sodium-potassium pump fails, and that's why diffusion MR lights up. Because that water is stuck in the cells and can't diffuse out. And And so this is the new data. And I'm purposely not showing you any of the data because I don't want, just in case anyone's taking a picture of it, to say they really published it or they won't publish it. But this is a cartoon thing. And you can see from the cartoon that we do something where we quantify the degree of hyperdensity. And we have a little mnemonic for that. That quantification is called NWU, net water uptake. So we can actually quantify the ischemic hypodensity. And you can see the net water uptake starts to be visible even when only the diffusion is positive and predates the flare. And both the diffusion and flare are all or nothing. And so not only is the net water uptake more interesting because it's earlier than the flare or anything except the ADC, but it's also more interesting because it's almost linear. And it's showing you almost like the time progression, and there's this hidden stage of edema called ionic edema. What is ionic edema? Most of you have probably never heard of it. Anyone who's a stroke researcher has heard of it all the time, but we never image it. And we just realized we're able to image it just by looking at the early non-contrast CT quantitative hypodensity. And the ionic edema, what that is it's before the blood-brain barrier breaks down completely, but after you have that failure of the sodium-potassium pump, and some of the tight junctions in the vessels start to leak out sodium and potassium and hydrogen and ions, and water follows that. So you're basically getting a very mild osmotic edema, and that's what ionic edema is. And you really can only see it on CT. So it's very cool that CT, in some ways, is actually better than MR for all of this. And so we leverage this, and we've been doing a lot of trying to develop some AI software that could also detect this early. And we're very, very lucky at MGH because we're one of a handful. I could probably think of 5 places, and there's probably close to 10, but I can think of very few places that have a CT scanner and an MR scanner less than 30 feet apart, both in the ED. So we, for over 20 years, have every single stroke case, CT, CTA, CTP plus or minus, because I'm going to tell you I hate CTP. We don't like CTP. But there's some things it's good for, but not for selecting patients for treatment, because it has excluded patients unnecessarily. With CTP, you overestimate the core when you're really looking at the penumbra, and patients have been excluded from treatment who would have benefited, just because you're overestimating the core. So I don't like CTP. I don't think it should be used. It's useful, but not for making the thrombolysis decision or the EVT decision. Okay, but we had this unique data set where we had immediate diffusion following, so later than the CT scan, after the CT scan. So if anything, we were biased towards not seeing the stroke on the CT scan because the diffusion was after that. But what we did is we trained an AI, and if you look at the original CT in the middle, and there's your answer, there's the diffusion. I dare any of you, I can't see it, I dare any of you to find the stroke on that CT. But because we trained the AI on a gold standard, ground truth of thousands of diffusion scans, it picks up something in those images. It's seeing more noise or some texture thing or something that the human eye can't see. And so it is very accurately, even super early, outlining the stroke, very close to the DWI. And those outlines, when you can't see it well with your eye, that's probably the ionic edema. So there you go. And we published that in Nature Scientific Reports, and super, super accurate, way better than humans. That little red dotted line is the ROC curve, sensitivity and specificity for the humans. And who are the humans? You know, the best stroke neuroradiologists in the world. couldn't see those things. And we had like 10 readers, all with 30 years or more of experience. The AI did way better. Way, way better. All right, but there are some pitfalls, and now we'll speed up. So basically, there is subtle right obus pallidus putamen. You see, you're not quite seeing it symmetrically. And if you windowed it, it would be even better, but you know what? That's just because the patient was tilted in the scanner. So be careful of little things like that, just little pitfalls. You gotta look at the whole case. I already showed you this earlier today. That little hyperdensity, when we looked at this coronal and sagittal, was just a detector out in the scanner that was forming a ring of bighorn in artifact. But unless you look at the sagittal and coronal, you don't know that. So, we saw that already. And I have 3 minutes left, so we're going to fly through stroke. Let me just tell you some big take-home messages. It used to be that most strokes were from carotid artery emboli, but we've gotten so good at screening and treating for carotid stenosis that most of the strokes we see are coming from the heart. I will give you one other really important statistic that's not on this slide, and it's only thing important I have to say that is not on this slide, which is 70% of all strokes due to any cause would be prevented if you just had good control of hypertension, if you just treated hypertension. And that, of course, includes lacunar strokes, but that's why in my report, if I see a lacunar stroke and it's new, I always put it in the impression, because that means even if they know the patient is hypertensive, it's not being well controlled. And probably the biggest public health thing you can do to save that patient in the future is let them know that hypertension isn't being well controlled. If you see a new lacunar injury, okay? Rare causes of stroke, non-hepatic hyperglycemia, which looks dense on CT, versus central conti-myelinolysis. All right, here's a quick, everyone just think about this. Just look at the name of this New England Journal of Medicine, CPC. What's the key word here? There's a word that gives you the answer. What is the word that gives you the answer, and what's the diagnosis? Someone shout out the word in that title of the case. The word is transatlantic. So if I tell you the word is transatlantic, what is the diagnosis? The diagnosis is a paradoxical embolus with PFO. So I just had an 8-hour flight. I made sure I kept moving my calves, because if you have a PFO and you're sitting in a plane for 8 hours, that's how Teddy Bruschi, who was one of the halfbacks on the Super Bowl winning New England Patriots, and I'm not breaking any HIPAA regulations here, this was in all the Boston papers, but he had a stroke flying to the program. And he went to Hawaii from Boston, and he just sat the whole time, and when he stood up, he got a little stroke. And that was the diagnosis. This case, by the way, is not here, but it's not infrequent. All right? I'll let you study all of this on your own, but the only one I would point out is intracarotid artery. Make sure you recognize that pattern over there on the right. Intracarotid artery is kind of posterior and internal capsule. It's very rare, but when you see it, it's very useful. And Jeremy has published this in a lot of different places. I'm not going to talk about dual energy. I didn't talk about it last time. It's already on the scope here. But what I do want to say about dual energy is simply that you can tell hemorrhage from calcification. You can tell iodine from calcification. So you always get post-thrombectomy scans, non-contrast CT. You never know if we're looking at blood or blood-brain barrier breakdown from contrast in the basal ganglia. But with dual energy CT, you can tell. And so if you have it, use it. They're now doing photon counting CT. The new detectors are being made at CERN, which is the same place they discovered the Higgs boson. And they're actually using the same detector electronics that is the Atlas detector that discovered the Higgs boson to make every single new photon counting CT scan for every single vendor. And that's why they had a photon counting CT meeting at CERN in Geneva on the French border. All right, so the relevance of this to this talk is that If you have a spectral CT that you could tune to material decomposition, you could get it to like liquid water, and you can make the virtual monochromatic KV to make the hypodensity pop out of the water. And so this is all work in progress, but people are trying to see how do we optimize this dual energy CT to see these subtle hypodensities even better. I'm not going to talk about thrombectomy because we're out of time, but I will tell you that all of these 2015 6 major clinical trials to prove that endovascular thrombectomy works all failed. They failed to prove thrombectomy works, and a big part of the reason, we could give a 2-hour talk just on this one slide, but a big part of the reason is that here's the bottom line. The bottom line is that they were only using the non-contrast CT for the triage. They didn't have a CTA. And they were selecting a lot of patients who just didn't have large vessel occlusions, but they got included in the analysis. It was an intention to treat analysis. So it diluted all the results. So they went back, and within 2 years, they not only were able to show that thrombectomy works, they were able to show it works up to 24 hours. And some of you may know Raul Nogueira, my good friend, who is from Brazil, and he lectures a lot in Portugal on this topic, but he is really the leader in the thought from all of this. And a lot of the stuff I'm saying is stuff Raul taught me. But at least in the US, CTA is literally the standard of care because it's on the FDA package insert for the thrombectomy catheters. And you're not allowed to open a thrombectomy catheter unless it's off this clinical trial that used CTA for patient selection. So we won't go through how to review it, but I will say if you're doing the CTA, again, check. You might be the only person that knows that they intubated the right main stem bronchus. Just, you're responsible, you're a radiologist, you're responsible for everything, not just the brain. So, and I was going to go through this whole case, but we're out of time, so I'm going to just skip ahead to what's really important. I have 2 or 3 take-home messages. And one is, what you get for free when you do a CTA is looking at the collaterals. And there's really only 2 things you have to be aware of when you look at the collaterals. Everyone does multi-phase, everyone has different programs, protocols. General Electric has a color flow thing that labels all the different phases. There's only 2 things you need to know to make really good use of collaterals. And that is number 1, is it a malignant collateral pattern, which basically means there is 0 contrast reaching more than half that territory at risk of the ischemic hemisphere. That's the malignant pattern. But even more important than the malignant pattern, because we're not trying to rule out patients from treatment, we're trying to rule in patients for treatment. Even more important is symmetric collaterals. And basically, if the collaterals are symmetric, it means they're a great candidate who's very highly likely to benefit from endovascular thrombectomy. And you can do all your CTA analysis, you can do your CTP. This gives you, there's 3 categories: likely to benefit, unlikely to benefit, and intermediate. Likely to benefit is symmetric, unlikely to benefit is malignant, everything else is in between. Like the 2 extremes account for like 80% of all stroke patients. And how do you know if it's symmetric? The easy way to know if it's symmetric is if you look at it without looking at the vessel occlusion, and you can't tell which is the ischemic side, it's symmetric. And be careful, because you might think, well, if I see a lot more vessels on one side, then the opposite side is probably the ischemic side. But don't forget, before the collaterals collapse, they actually have delayed venous outflow. And it could look like there's more collaterals on the ischemic side because there's very sluggish flow there. So that's not going to help you. If you look at the thing and can't tell which is the ischemic side without looking at the vessel occlusion, just call it symmetric. And the final thing I'll say, and I'm going to let you read this article, the final thing I'll say is that the insula gives you a lot of information. And if at admission, and this works for CT as well, if the entire insula is infarcted, it falls in that malignant category. If less than 25% of the insula ligament, this very first slide here, it falls in the symmetric category. And the people who fall in the symmetric category have very low infarct growth and very low infarct volume at admission. So just symmetric, malignant, or in between, which is free information that you're getting if you want to look for the CTA for vessel occlusion. So if you're not doing CTA for stroke, and there may be very good reasons, I really, really strongly encourage that you do. And it doesn't need a lot of fancy post-processing. Is there a large vessel occlusion? Are the collaterals symmetric or not? That's all you really need to know. Those are the two questions. And that's what I was just telling you about both infarct volume at admission and infarct growth. And so basically, I'm just going to skip here to these large core trials, but basically, there were about 6 big trials that were just done of just very low aspect score. Can you still treat it? And the answer is, at least going down to an aspect score of 3, and you'll notice that I was on 3 that did this analysis of all these trials. And we don't really have enough data down in 0 to 2 or beyond 12 hours, but at least in the first 12 hours, an aspect score down to 3, the benefits of treatment exceed the risk of hemorrhage. And so it's worth treating. And those are, every major society is coming out with those guidelines right now. This is why I don't like CT perfusion. We already said this, but I knew this back in 1989, and my mentor, Dr. Ackerman, was scanning these patients with PET, but before you had IV TPA and before you had thrombectomy, there was no treatment, so there was no hurry to get these scans, so they were all done late. But because they were all done late, they actually provide another reason why CTP doesn't work. And it turns out we have something called misery perfusion. Part of the reason CTP doesn't work in the late window is that you get non-nutritional flow, the vessels, the collaterals start filling in. So the perfusion isn't giving you the same information in those late windows. And we knew that back then. And remember, always look at the basilar. Tenecteplase has replaced alteplase. And the jury is still out on whether you should do IVT without EVT. That's an open question both for basilar and for interior circulation. So this is our flow chart, and thank you.